It is now my pleasure to introduce this morning's keynote speaker. Hannah Kettler, Ph.D., is a senior program officer on the Life Sciences Partnerships team at the Bill and Melinda Gates Foundation, where she is responsible for the LSP Thinkubator and leadership engagement initiatives. In this role, Hannah manages the Gates-CEO Roundtable, a coalition of the CEOs of 17 global pharmaceutical and diagnostics companies, and the Gates Foundation leadership and the foundation's grant with Japan's Global Health Investment Fund. Dr. Kettler's work focuses on the intersection of industry, finance, and global health and policy. She's passionate about designing innovative partnerships and sustainable financing vehicles and policy change to mobilize corporate investment in global health. Please join me in welcoming Dr. Hannah Kettler.
Thanks very much. Thanks, Tammy and Ulrich and Brian also for the invitation to join you here today, and also to HTAi. I have to say, I already feel at home. You have more acronyms than I do in my world, and so I have a lot to learn while I'm here. I also want to acknowledge the value of not having Uber in Vancouver and how pleased I am with all the bike paths. As a bike commuter, I'm very pleased and feel very welcome in Vancouver. And finally, just to say, I'm very drawn to the circle, the vision of inclusion and collective action. And a theme of my remarks today also speaks to the importance of inclusion and the reality that no one player can solve any of these problems that we're focused on. And as much as I will speak quite a lot about the Gates Foundation, the foundation sees itself incrementally and intimately linked to a significant family of partners. And I look forward to welcoming most of you and all of you into that family to work on global health issues. So 2 weeks ago, Melinda Gates opened our annual meeting. And this is a meeting that brings together all of the Gates teams from across the world. And she started with a very bold statement. She said, "We are here and we are changing the world." She didn't say we will change the world or we can change the world. She said we are. And importantly, she was speaking not to those just in the room, but again, acknowledging the importance of the partners and the partners that execute, sharing the vision that we have, that all lives have equal value, and that all deserve an opportunity to lead a healthy and productive life. And so again, as we start this conversation today, recognizing the value that all of the work that you do potentially brings to the challenges that we work on. Health technology assessment is a critical piece that will help execute and accelerate the work that we're trying to do to improve the lives of the poorest in developing countries. And you can play a critical role with your evidence to inform decision makers, companies, industry, as well as patients about how best to utilize scarce health resources and also how to value health products that have great benefit to the poorest in developing countries. The global health field has enjoyed a renaissance of sorts over the last two decades. Traditional health players and advocates, health organizations have been joined by the likes of Bono, so rock stars, billionaires, CEOs of pharmaceutical companies, so unlikely partners, ministers of finance. I mean, imagine we were part of a collective of Russia, Italy, the UK, Canada, all working together to really support and advance the priorities of global health. So those partners together with new funding and the technological developments, the advancements that we've seen over the last 20 years from the biomedical fields, from the academic science and the industry science that has happened, those all come together to really generate a sense of optimism that we really can change the world and have an impact on the global health problems that have persisted over the years. And I guess I should be using a clicker. There we go. All right. And we've had progress. We've made progress over the last 20 years. We've seen it. So just since 1990, child mortality has been halved. And that's really a testament to the importance of vaccination, of increased use of malaria prevention, improved nutrition. And it helps demonstrate the fact that tools are getting out to the poorest and having a real impact. Many of you have signed on, or at least have been part of conversations around the Sustainable Development Goals. And together, we're committed to try to have this again by 2030. And that's not going to be an easy feat, but it's feasible, it's doable, and it's a really exciting time to think that we can bring child mortality down to such a low level. Polio. We've only ever eradicated one disease, smallpox, and we're so close now to eradicating polio. India was never perceived as being, it was always going to have polio cases, and it's now polio-free. And at this point, we're still trying to battle the remaining polio cases in the war-torn areas of Afghanistan and Pakistan, as well as in Nigeria. But we're very close, and that's exciting. Neglected tropical diseases. Again, many of these diseases I can't pronounce, and most people have never heard of, like lymphatic filariasis, trachoma, schistosomiasis, terrible parasitic diseases, worms, horrible things that most of us never think about, never worry about, because they're necessarily diseases of the poorest. And an amazing coalition has come together, again, of pharmaceutical companies, donors, countries, and there's a real effort towards trying to eliminate or control 10 of these diseases by 2020. HIV. As we know, HIV sort of was an epidemic that almost came out of nowhere, and in a very short time was suddenly having a huge impact, killing millions of people. In also equally short order, and I give a lot of credit to the pharmaceutical companies that may be represented here today, new drugs were developed very fast. This is a really important evidence of where there's a market, R&D and product development really responds quickly. At the same time, many of those companies have then in turn been close partners with donors, nonprofit organizations, and other companies to try to accelerate the decrease of the prices, and that enables the affordability and thus the distribution of those antiretrovirals globally. And you can see the impact here, significant. New funding is really important, so PEPFAR, US funding dedicated to HIV, but also the global funds. So funding is very important, but also the tools. I would say we cannot take this progress for granted. We do not have prevention tools for HIV at this point. So we have treatment, but it's made it a manageable chronic disease, but it is not yet a preventable disease. And so innovation is continually important in this field, as is the continuation of funding for HIV. So with this progress, we still have a lot left to do. 3 billion people, so half of the world, is still living under $2 a day. And this translates into the persistence of where, this demonstrates where the under 5 mortality continues, children under 5. So there's a close correlation between poverty and the location of disease and infectious disease. You may not be able to read these words, but the colors mean something. So many of you have probably worked with IHME or may in fact be partners in this effort to put together epidemiological data globally. So orange represents infectious disease. If we had the same picture up for the United States, it would be all blue and green. So for the low-income countries, orange or infectious disease persists. And these are diseases, frankly, that most of us don't think about that much, because actually, thanks to economic development, for the most part, we no longer have malaria. It's not a big issue for us. And so it's that out of mind, therefore low priority, that reinforces the likelihood of persistence of these diseases in developing countries. So this is the space into which Bill and Melinda stepped. They made a decision to take a big bet to use resources they had to try to catalyze others to get involved in global health. And, you know, we're a big organization. We're actually the largest philanthropic organization in the world. But even at 50 billion over 15 years, that's still really a drop in bucket when you think about how much it will cost and does cost to develop full functioning healthcare systems. You all know that. That's what you do in your daily lives. A significant part of that funding does go to global health, and we think of our funding as being catalytic, of being important because we can use our voice and bring visibility to the priorities that we have, and therefore through strategic leveraging, as we say, try to bring in corporate and public investment to make our funds go that much further. And again, you'll see quite close alignment between the issues that we focus on and the diseases that persist in the developing world. So new products, innovation, we talked about that already this morning, is critical to realizing our ambitious goals of controlling and eliminating many of these diseases. And yet, the market doesn't work, the math doesn't work for these diseases. It's clear that when there is a market, when there's a profit to be made, the pharmaceutical, biomedical R&D engine works very well, very responsive. For the diseases that we're talking about, that does not work. Again, this is a very simplified version of a way that the pharmaceutical industry might take a decision about where to allocate their R&D funds. But in short, the return expectations, even when you throw in halo benefits, essentially refers to intangibles, benefits from being visible, being perceived as being a good guy, or potentially, more importantly, leveraging investments into infectious disease and global health as a means to either build out their research and technology capabilities or enter new markets. Even with that included, it's very hard to come up with a positive that exceeds the hurdle rate or the opportunity cost of not doing something else. And so this is where we focus a lot of our attention, where I've spent a lot of time in my day job trying to think about ways that we can try to influence the math, try to impact this equation. Not surprisingly, considering the co-chair, Bill Gates is a strong believer in markets. And his real challenge to all of us is to say, how can we make the most of these markets, of the market dynamic in favor of the poor? He coined a phrase, creative capitalism, when he spoke to the idea of bringing the profit motive and the philanthropic motive together and trying to leverage that combination in order to really drive change. Can we influence investment decisions by the private sector? I just want to take a step back and say, we can't do this work without the pharmaceutical industry. I know all of you are very firm believers in leveraging comparative advantage when you see it, and you need those who know how to make drugs involved. So the option of substitution of purely funding nonprofit and academic partners alone probably won't allow us to get to our goals as quickly as we want. And so we necessarily need to figure out ways to bring those respective resources together. So very simply, again, thinking about the equation, the steps that we've tried to take are: one, try to push people in by reducing the costs and some of the risks associated with working in global health. And then pull, again, trying to create the markets that make them more certain, more attractive as a means to influence investment decisions. I don't have time to go into the details of many of these tools, but just a few examples. On the push side, one of the key levers or mechanisms that we've used is to invest in organizations that we refer to as product development partnerships. So dedicated organizations such as PATH, Medicines for Malaria Venture, TB Accelerator. See, I'm using words, not acronyms, in an effort to keep you part of that conversation. These organizations are nonprofit who are dedicated to trying to enable product development in some of these key areas. And they fund pharmaceutical companies, academic researchers, biotech companies to work on in let's say malaria's case, malaria drugs. But in addition to funding, they also serve as a partner to help the researchers work in the developing countries, figure out how to enact their clinical trials, work with the regulators. So again, in an effort to try to ensure that the risks that these organizations bear is minimalized. They're also the organization that are managing the portfolios. They're helping to make decisions to ensure that the resources are aligning with the, quote, best potential tools that we can. We can't afford to push everything forward, and so again, they play a role of resource management using target product profiles that are collectively developed by the community and helping drive R&D resources in that direction. So that's an example of a push. Example of a pull. In cases where, and again, a big issue with the pull and the lack of markets is certainty. So if we develop a product, we're not clear that there'll actually be anyone to buy it. We don't know how to work in these markets. Clearly, the ability to pay is low, but also the ability to aggregate is challenging. And so one thing that the foundation has done is use volume guarantees as a way to try and encourage investment in introduction of tools into developing countries. A good example is a contraceptive, an implant. So implants were developed in response to demand within the developed world. But in order to get products into the developing world at a sufficiently affordable price, we needed much more significant volumes and also much lower prices. And in order to encourage that, encourage companies to take the risk and cut the price, the foundation has used its balance sheet to offer volume guarantees. So in the event that the demand is not forthcoming, and we anticipate it will backstop some of the risk that companies have taken to cut their price. Another example is something called a priority review voucher. I would say it's also exciting to see in this world that we have new policy tools. This is an example of essentially a golden ticket, that if you're a pharmaceutical company or a nonprofit or a biotech company and you bring a new global health product through the FDA and get approval, you earn a voucher. And that voucher is for a priority review that you can apply to a product of your choice. And so this is a means through which companies are able to potentially accelerate a product of their choice getting onto the market. And how much value that is based on the company's pipeline and their perception of the importance of getting there quicker. These are tradable vouchers, and through that means we've been able to see that the average value of a tool like this is about 200 million. So what does that mean? 200 million is not enough to pull a product from early discovery through to market, which can cost over $1 billion, but it is enough to, in combination with some of the push funding, to get companies to keep driving products forward to market. Beyond these interventions that the foundation has utilized to try to engage companies to do more, we've also invested quite a lot of our resource in trying to improve the product development process. As you know, scarcity drives creativity. We can't afford to take all the steps and spend all the funding that others can to bring products to market. And we all know the product development process for pharmaceuticals is not particularly, it's not optimized at this point. It's not as productive as it can be. And those interested in global health R&D have a really strong investment in trying to make that even better. So the foundation's engaged with regulators to try to expedite the regulatory process. A good example of that is in Africa, to try to avoid a situation where someone needs to get approval in every single country. There's been effort to try to regionalize and harmonize regulatory decisions so that you can go to 3-4 places at most with your product to get regulatory approval, as opposed to every country on the continent. So that's one example. The foundation is also looking into ways to expedite failure. If we can fail sooner, we actually save money, because the late stage development trials are actually what costs the most money. And so we want to get things tested earlier and have tried to push on what can we test in parallel. We just recently established a new organization called the Gates Medical Research Institute, dedicated to the business of translational research and translational research science. How can we optimize that? This is the kind of work, in fact, that the private sector will benefit from and will actually appreciate. It's just a public good that they would never bother to invest in, because individually they can seek reimbursement from the developed world for their products, so there's no incentive to seek all these ways of saving money. But yeah, in global health, we have a real vested interest in doing so. So we talk about shifting the curve to the left. How do you fail sooner and quicker so we don't waste money on things that aren't going to work? So how have we done? There actually have been quite a lot of new products that have made it to the market. Many of these, again, recognizing we've only been doing this for about 10 years, that's not enough time to pull and push products through from early discovery. So many of these are incremental improvements, I would say, on things that already existed, or things that were on the shelf. Symbolically very important, and in some cases really significant, to improve the toolkit of resource we have to address some of these diseases. But we're not quite there yet. There's huge things that we're still missing. We really want a TB vaccine. HIV vaccine, we don't have yet anything that really works to prevent. What about cure HIV? We haven't made that there. And the question is, how are we going to achieve that? How will we ever move that type of science forward? One is clearly to make even better investment decisions and working with the right partners and engaging the best science to try to accelerate work in these fields. Another real issue is volume, right? Failure rates. 90% of products do not make it to market that are started. You need much more hits on goal than we currently have. Push funding is a fairly transactional business. You pick things and you push them. But if you don't have real momentum, if you don't have a sustained system that mobilizes numerous people to take shots on goal, you have a harder time really solving some of these challenging problems. So even as it is critical that we recognize and figure out how to use some of these tools, and again, really important roles for all of you is to figure out which of these should we prioritize for distribution and which not, we are still missing a sustainable system that really can make a difference in the long run against some of these hardest problems. So a question to finish my remarks is to make a pivot and ask a question about, so where do we go to find that new markets? I mean, essentially, when you talk to companies, they say, cost reimbursement is really attractive, but actually, markets are what drives us. So where do you go to look for that market? You continue to try to raise huge funds of money from the developed world through aid, but we all know that aid is not necessarily reliable, and in fact, in this current era, there's a lot of question about how much we can count on even the existing levels that we have from some of the key countries, the US, the UK, Europe, and elsewhere. So raising huge pots of money seem unlikely in the long term. So what about the countries themselves? We have tended to treat the world in two boxes, rich, poor. And the reality, as we know, that's not the case. Highly differentiated, the spectrum of low to low middle to low high. And the disease burden is different in these countries, but also the economic status and ability to pay varies significantly between these countries and within these countries. And so a key question, a challenge, is there a way to better leverage some of that buying power on behalf of global health specifically? There's talk about transitions. Countries are evolving. Thankfully, there's economic development that's pushing countries away from being aid dependent. They're maturing. With that comes a lot of issue that I'm not going to get into about what does it mean to no longer have access to aid, and how quickly as countries are you able to assume responsibility for the procurement of tools that up until recently someone else is paying for. That's a huge issue. And again, work that Calypso and others are doing to build health technology assessments in these countries is critical because that will help inform decisions as countries take on more responsibility for health expenditure and allocating their own resources. So countries are transitioning, and the other really important thing is that the poor are disproportionately actually living in middle-income countries. And so for us as Gates Foundation, as other funders, as all partners, the challenge of how do you access and ensure that the poorest maintain and continue to improve as far as health is concerned, we need better strategies, we need different strategies to actually access the poor in these middle-income countries. And arguably we need to be looking to how do we partner with these countries to ensure that they themselves are maintaining a prioritization on their poorest as they also then respond to new challenges that have to do with the shift towards non-communicable disease, away from infectious disease, chronic disease, much more expensive, much more challenging to address, and yet they have the poor as well. Big challenges. Spending more on health. Again, how do we work within these countries to ensure that they're able to make good decisions? So the key question, and again, a shout out to Calypso and the work that she's done to build healthcare and HTAi capacity in country. An interesting question to leave with is that of not just can these countries assume responsibility for paying for the tools that exist, but is there any way to use the potential, the future potential buying power of these countries as a pull? Now again, product development decisions get made 10 to 15 years in advance of the product actually being on the market. And for a company to sustainably invest in that product, they need to see certainty that if they build it, someone will pay for it. And is there a way to take advantage of the fact that countries are spending more on health and really invested in exploring how do you build out value for money price systems? The question that, again, it's in this case Calypso and Adrian Taus, who's also, I think, here, they're working together with the foundation on the specific question of, is there any way you could ex ante, so before a product is made, think about a target product profile that includes what they might pay for it, what value they may assign to that product should it meet that target product profile. And is there any way to aggregate that demand in some kind of convincing way that that would drive investment decisions? And so that work is ongoing. Again, I'm not going to attempt to describe this circle at this point because I'm actually still trying to figure it out myself, but the ultimate objective is there a way to securitize, make certain so as to motivate investment decisions now with an eye to working with countries and having them think about what would it mean, in this case TB, what would the value of having a new TB drug that is both useful for drug sensitive as well as multi-drug resistant TB? How much would you pay for that? What value? And would you be willing to commit now to a price that in the future you'd have to make good on if that product comes to market? To me, this is creative capitalism at its best. And it's super exciting. So in closing, again, I want to thank you very much for the invitation and the opportunity to speak about global health and the Gates Foundation. I also really want to reinforce and leave with you the feeling and the opinion that as we move forward, the role of the work that you do, the evidence that you create, become ever more important, ever more critical as we pursue these ambitious goals that we have. The decentralization, if you will, of decision-making to countries is a positive, but it's also a real challenge. And we're going to need all of your skills and capabilities to really mobilize decisions that align with priorities and needs of the poor in order to continue our work. So with that, I'd like to thank you and happy to take any questions.
Great. Thank you so much, Dr. Kettler. We do have maybe a couple of minutes if there happen to be any questions from the crowd. We do have microphones in the two main aisles. I think you've given us a lot to think about. Oh, I see Dr. Cliff Goodman heading for the microphone. Thank you, Cliff.
I was actually headed out, but you caught me.
Oh, I've called you.
Thank you for the wonderful presentation. It's very encouraging to hear that you're thinking about rebuilding and designing economic systems to encourage this. Can you say more explicitly anything about how an evaluative or an assessment function can be or has been built into your thinking for product development? A little bit more on the assessment role insofar as those are concerned. Thank you.
No, that's a great question. So within the as the foundation itself makes decisions about where to prioritize its resources, we have increasingly been building a more sophisticated, integrated portfolio management tool, as we simply refer to it. And essentially, there we're trying to balance between what diseases have the largest potential, what are most important, what needs to be solved, where might we make a real impact. So if you look at cost saved per DALI, what have the most potential for impact, assuming success. And so we are trying to work with those three variables as a means through which to make decisions about where we put our funding. As far as the target product profiles that are under development and the value for money, I would say historically it's a relatively new place. It has up until now often been the case that as you talk about access, affordability is really used as the proxy. And it's like, well, how cheap? But anyway, the focus has been on we need low prices. And part of it is, as you engage in early stage research, it's sometimes hard to know what cheap enough actually looks like, and also not yet to know the value of the product itself. But I would say it's a relatively new emerging field, and there's a lot of room, in fact, to integrate that type of thinking into TPPs, especially because, as we know, I would say in some ways to get momentum and in some ways to encourage donors that you can actually do something in this space, there's been quite a lot of pushing things forward that one might, if they did a really aggressive TPP that included value-based, might have argued 10 years ago might not have been a good investment, but it's definitely a work in progress.
Great. We have another question. This microphone, please maybe introduce yourself and let us know where you're from.
Sure, my name's John Gillespie. I'm from Australia. I'm with Medtronic, a medical device company. So I'm going to take my company hat off here, and I'll just be asking a question as a well-informed member of the public. The health minister's comments on Uber and opioid abuse really got me thinking. Is this community at the danger of thinking too much about single technology appraisals versus thinking about spending our efforts on public healthcare interventions? See, for example, in many developing countries, a lot of the problems they have been addressed in the rich countries by access to clean water. Mm-hmm. I hope my question makes sense.
Yep, no,
there's a lot of brains in HTAi all over the world. Maybe we need to think about where we can direct our efforts.
Yep. No, great. Thank you. Really good question. And there definitely is a dialogue around that pivot from vertical programs. So the implication of having HIV funding, malaria funding, TB funding, absorptability of all those tools individually, but also the challenge for countries to make comparisons about the relative importance of those tools. I would say, as using the Global Fund as an example, at least in principle, it was set up as a vehicle through which countries themselves would make decisions based on their assessment of where they felt money would be best used, whether that was to improve health systems, to procure products, some combination training of healthcare workers. So again, in theory, it was locked in around HIV, TB, and malaria. But it was set up again with the allowance for country decision-making, country assessment. The foundation itself clearly recognizes that even just from a practical matter, our ability to have impact against the strategic verticals that we have is limited by the absence of a really strong public health system. And there is an increased commitment. We have a ever-growing integrated delivery team, also investments in new offices in Nigeria, Ethiopia, a greater geographic presence, with a recognition that ultimately long-term our investments will need to be readjusted to focus on the building up of public health systems, again, even as we pursue innovation and technology. Thanks.
Go ahead, Alicia.
Yes, well, thank you for the presentation, very inspiring. I was wondering, meanwhile, you were presenting that you are talking about very concrete diseases, tuberculosis, malaria, etc. But I'm wondering how you arrive to know which people is ill. Do you have a partnership with infrastructures, type of primary care? How you get the people? How you know which is the people, where is the people to treat?
Yeah. And is that, just so I can clarify the question, is that as a means to decide what we should be spending our money on, or as a means to realize the impact we're looking to have, or both?
No, real life, in terms of you have the funds, you have the possibility to provide some treatments or to invest in the research of treatments, but how you get the epidemiology or the number of people or the infrastructure, the primary care, in order to get the people to be treated?
Yeah, no, that's a great question. So the investment that the foundation's made over the last, I say, 3 or 5 years on the generation of evidence has stepped up significantly. So I made a reference to the IHME, which is a team, they're now at the University of Washington, that we've made a sizable investment into building up the ability to do epidemiological analyses of what are the key diseases, initially by country, but increasingly by region. We've also invested in a team that's very focused on improvements in surveillance technology. We've just recently invested in something called, I think it may no longer be called CHAMPS, but originally it was called CHAMPS. And it has to do with doing autopsies, non-invasive autopsies on children under 5 as a means to figure out what's actually the source of death of these children. Because you can assume they have a fever. You don't really know. Was it malaria? Was it pneumococcal disease? So we are aware that that's really critical and are investing in that information collection with a goal to trying to be more precise and more targeted. So thanks.
Great. So just so people know, the last 2 questions will come from this side of the room, just to keep us on time.
Hi, I'm Alans Chopra, Professor of Health Technology Assessment in the UK.
Hi.
A quick question. Where in your framework does digital health fit? So you might have a new drug for TB, but we know that drug-resistant TB is because people don't complete the medication.
Yep.
So you can use serious games, you can use various approaches to encourage and change health behavior.
Yeah, no, that's a great question.
And similarly with HIV. So there are a lot of people out there developing interesting things, but they don't really know how to target them. So how will you draw on that expertise?
Yeah, that's a great question. And again, it's somewhat related to the one previous, which is, so this issue of adherence. And so again, backing up to, initially access really ended up translating into price, right? So affordability, but clearly appropriability is critical as well. And so I would say, and again, this is an area that the foundation's relatively new in, but the balance between, and I would say the most progress has been done on the family planning team potentially, as well as in HIV, where there's been a real, in India as one example, like really trying to understand who are the people that are being impacted by diseases, who is most vulnerable, and then targeting interventions more specifically to try to address and get ahead of. In India, in HIV's case, it was an attempt to try to prevent cases, so to try to get ahead. We are, by definition, also interested in technologies, and there is quite a lot of investment also in how do you improve the tools that we have to try to make them easier to take, easier to monitor. There has been relatively recently some investments in things that also are critical in the US and Canada and elsewhere, which just tries to remind people, maybe using mobile phones to take your medicines, try to link people more closely to physicians. So it's an evolving area, and I'm not involved enough to speak to the set of partners that are involved, but it is an area that is of attention and interest to us. So, thanks.
Iñaki Gutiérrez Ibarlucea. I'm the Vice President of HTAi and part of the Basque Office for Health Technology Assessment in the north of Spain. Thank you very much for your talk. It has been very impressive. On the other side, I have a couple of questions. One it is, you have talked around most of the things that we can implement in lower middle income countries, and most of them were related to treatment and prioritization of new technologies that could help in some of the neglected diseases. But what about prevention and how you are going to tackle that? And on the other side, how you are going to tackle also another problem that we have in low and middle income countries, that is that we go with high income countries perspective, and we don't go, for example, on disinvesting things that they are useless in many of those countries, and they are still implemented because of the advice of many advisors coming from high income countries. So those are my two questions.
The second question, just so I'm clear, is that speaking to the fact that now that non-communicable disease is increasingly important, the solutions from the developed world are kind of being introduced without sufficient evidence? Is that what you mean for the second question?
No, the other one was prevention and prioritization of care. Yeah.
Okay. Well, first to prevention, and I think it's interesting. It's always great to get feedback on what sort of message you end up sharing. In fact, vaccines and prevention are fundamental and really core. We've probably spent more funding on trying to scale up the use of vaccines and also investing in prevention as the most affordable way. And so as much as I guess I overplayed the drug examples, we definitely have our pneumococcal portfolio, our enteric disease portfolio, as well as I say the big bets in HIV, TB, and malaria are all around prevention. Less behavioral. I think that we haven't done as much on the, and back to the question prior, sort of how, with a few specific examples as exceptions like India and HIV and some in South Africa, we haven't done as much behavioral change, but we have invested significantly in prevention tools, recognizing that ultimately we'll never be able to retain, I mean, HIV is the perfect example. That's not a sustainable situation to continue to manage even at more attractive and more affordable prices. So thanks for your question.
Thank you.
Thank you, everyone, and thank you, Dr. Kettler, for your inspiring and thought-provoking talk. You've definitely given us a lot to think about. And so with that, that brings us to the end of our welcome ceremony.